Hi, welcome to the lecture series. In this lecture, we will discuss about the functional abnormalities of the thyroid. As we discussed earlier, we are concentrating on three kinds of abnormalities of thyroid. They are epidemiological abnormalities, functional abnormalities, and morphological abnormalities. In this lecture, we will concentrate on the functional abnormalities of the thyroid. The function of the thyroid is to maintain the basal metabolism. When the functional ability reduces, the basal metabolism goes down, and we call that hypothyroidism. When the functional ability increases, it is termed as hyperthyroidism or thyrotoxicosis. First, we will touch some important aspects of hypothyroidism. There are two kinds of hypothyroid state we need to know. First one is the congenital hypothyroidism and the second one is adult hypothyroidism. Congenital hypothyroidism presents in fetus or infants. When the development of the thyroid is totally failed, it is called cretinism. When the development is partially affected, it is called juvenile myxedema. So the cretinism is due to total failure of thyroid development. It's also called congenital iodine deficiency syndrome. It is mainly due to the poor dietary iodine during pregnancy. It also happens when the pregnant mother taking antithyroid drugs, especially carbimazole for hyperthyroidism. This is why the propyl thiouracil is given as antithyroid drug during pregnancy, especially in first trimester, as propyl thiouracil has less chance of crossing the placental barrier. At the same time, the radioactive iodine should not be given to pregnant women. If this condition is not detected during birth, the infant will develop impaired physical and mental development. Thus, the child will present with hoarse cry, macroglossia with protruding tongue, umbilical hernia with pot belly, and features of thyroid failure. So the diagnosis at birth is mandatory to prevent mental and physical impairment with commencement of thyroxine. Thus, the routine assessment with TSH is done for all the newborn children. Adult hypothyroidism is due to two main causes. They are iodine deficiency and Hashimoto's thyroiditis. There are iatrogenic conditions such as thyroidectomy, radioactive iodine, and antithyroid drugs also cause hypothyroidism in adults. Most of the systems are affected due to the low basal metabolism. Patients will present with tiredness, weight gain, cold intolerance, goitre, and hyperlipidemia as general presentations. There are few eye signs present in hypothyroidism as well. The lateral one-third of the eyebrow is lost and it is called madarosis. Similar conditions can occur in leprosy as well. Queen Anne, the Queen of Denmark's portrait, showed the similar kind of eyebrows, so this condition is called Queen Anne's sign. And there will be a bogginess around the eyes in hypothyroidism. The other systems affected are cardiovascular, hematological, skin, reproductive, and gastrointestinal. Hypothyroidism can lead to developmental abnormalities as well. Hypothyroidism is one of the commonest causes for carpal tunnel syndrome. For the investigation of hypothyroidism, the serum TSH and sometimes the T3 and T4 are checked. Elevated TSH confirms the diagnosis. Thyroid peroxidase antibodies are elevated in Hashimoto's thyroiditis. In the treatment, the thyroxine is used to treat the hypothyroidism. The dose is given according to the patient's weight. The usual dose is between 75 to 150 micrograms per day. In the elderly patients with ischemic heart disease, the thyroxine should be introduced cautiously, starting at 25 microgram and increasing the dose every fortnight in order to avoid tachyarrhythmias and cardiac failure. TSH need to be checked every 3 months in a patients with thyroxine treatment. There are complications occur in hypothyroidism. Such complications are thyroid lymphomas and myxedema madness. Thyroid lymphomas usually arises from the glands which are related to autoimmune hypothyroidism. And the other condition, that is myxedema madness, occurs in extreme hypothyroidism, and it can present with confusion leading to coma. The next functional abnormalities of the thyroid is thyrotoxicosis. The elevated level of thyroid hormones will lead to thyrotoxicosis. What is the difference between hyperthyroidism and thyrotoxicosis? Is it same? Hyperthyroidism is related to the excess synthesis and or excess secretion of the thyroid hormones from the gland. But thyrotoxicosis is the clinical syndrome due to excess circulating thyroid hormones. So the thyrotoxicosis can present in two ways. First, thyrotoxicosis can be due to hyperthyroidism. The second, the thyrotoxicosis can present without the hyperthyroidism. So you can understand now that in these both conditions, the level of circulating thyroid hormone is high. So that is what we call thyrotoxicosis. Hyperthyroidism can be due to two reasons. They are primary and secondary hyperthyroidism. In primary hyperthyroidism, the symptoms appear first with or without the goitre. In secondary hyperthyroidism, the thyroid swelling will be there for some times, then the toxic features appear later. The primary hyperthyroidism present in Graves' disease, so it is common in young individuals, and primary hyperthyroidism has mostly the eye signs. Secondary hyperthyroidism occurs in multinodular goitre. It is common in elderly individuals. Contrast to primary, the secondary hyperthyroidism will have more cardiac features rather than eye signs. It can present with tachycardia, ectopics, atrial tachycardia, and atrial fibrillation. The causes of thyrotoxicosis can be divided into thyrotoxicosis with hyperthyroidism and thyrotoxicosis without hyperthyroidism. The commonest causes of thyrotoxicosis with hyperthyroidism are Graves' disease, toxic multinodular goitre, and toxic solitary nodule. There are some other rare causes such as pituitary adenoma and metastatic follicular cancer. The thyrotoxicosis without the hyperthyroidism are thyroiditis and ingestion of thyroid hormones. The clinical features of thyrotoxicosis are due to excess thyroid hormones. This will lead to increased basal metabolic rate and increased sensitivity to catecholamines. The patients presents with features of thyrotoxicosis such as mental disturbances with anxiety, fatigue, and irritability, heat intolerance, increased sweating, palpitation, and dyspnea. Increased appetite and weight loss are paradoxical features. The other condition where this type of paradox occurs is diabetes mellitus. Thyrotoxicosis can develop diarrhea and menstrual irregularity. The examination of the thyrotoxic patients reveals the goitre, eye signs, and cardiac features. The goitre is associated with thrill or bruit. The ophthalmopathy are due to sympathetic overactivity or infiltration. Cardiac features are end organ effect of heart. When it comes to investigation of thyrotoxicosis, there are 3 steps. First, we have to confirm the thyroid status. Second, we have to determine the etiology. And third, we have to find out the end organ effect. To confirm the thyroid status, the TSH, T4 and T3 are done. TSH is the most sensitive and specific single blood test. In thyrotoxicosis, the TSH is low or unrecordable, while the T4 and T3 are elevated. When the TSH is low and the T4 and T3 are normal, it is called subclinical hyperthyroidism. Thyroid autoantibodies are done as first-line investigation to find out the etiology of the thyrotoxicosis. TSH receptor antibodies are elevated in 90% of Graves' disease, and this is elevated only in Graves' disease. Thyroid peroxidase antibodies or antimicrosomal antibodies are elevated in Graves' and thyroiditis. Thyroglobulin antibodies are elevated in 90% of Hashimoto's disease. Ultrasound scan of thyroid shows gland nodularity, echogenicity, and vascularity. The vascularity in ultrasound scan is increased in Graves' and it is reduced in thyroiditis. In doubtful cases, the thyroid scintigraphy such as technetium-99 or radioactive iodine scan is used. In radioactive iodine, the gamma rays of iodine 123 is used. You can note that iodine 123 is done for investigating purposes and the gamma rays are used. When it comes to treatment with radioactive iodine, the iodine 131 is used with beta rays. After the confirmation of thyrotoxicosis and the etiology, the end organ effects are assessed with cardiac and ophthalmological function. This is how the thyroid scintigraphy will vary in the 3 commonest causes of thyrotoxicosis with hyperthyroidism. In Graves' disease, there will be diffusely increased uptake. In toxic multinodular goiter, there will be patchy uptake. And in toxic nodule, focal uptake with suppression of surrounding thyroid and contralateral lobe is seen. The treatment of thyrotoxicosis. There are 3 kinds of treatment modalities for thyrotoxicosis: antithyroid medication, radioactive iodine, and thyroidectomy. The first line treatment is antithyroid drugs. It is very effective in Graves' disease, but cannot maintain the remission in toxic multinodular goiter and toxic nodule. Radioactive iodine is the first line definitive treatment option, and thyroidectomy is indicated in some patients with thyrotoxicosis. Commonly used antithyroid drugs are carbimazole, propylthiouracil, and beta blockers. Carbimazole blocks the thyroid hormone synthesis and it suppresses the autoimmune process in Graves' disease. This won't reduce the gland size. As carbimazole crosses the placental barrier, it is not used in pregnancy. Propylthiouracil will block the thyroid hormone synthesis it will block the peripheral conversion of T4 to T3 and reduce the thyroid autoantibodies. Propyl thiouracil is given in children and pregnant. Beta blockers such as propranolol block the peripheral conversion of T4 to T3. At the same time, it reduces the cardiac problems. But there are contraindications to use beta blockers such as asthma, heart block, and cardiac failure. There are two treatment strategies to use antithyroid medications, especially in Graves' disease. They are dose titration and block and replace treatment. In dose titration, high dose of antithyroid drugs are initiated and gradually reduced to the dose until the euthyroid state is achieved. In block and replace treatment strategy, the high dose of antithyroid drugs are started and then the thyroxine is added in 4 to 6 weeks' time. The side effects of antithyroid drugs are skin rashes, arthralgia, neutropenia, and liver dysfunction. Neutropenia presents with sore throat and the liver dysfunction presents with jaundice. So the blood counts and the liver function tests are checked regularly in patients who are on antithyroid medication. The second treatment modality is radioactive iodine. It is the favored first-line definitive treatment. It is given as iodine 131 with beta rays. This is different from investigative thyroid scintigraphy, in which the iodine is 1 to 3 with gamma rays are used. Graves' ophthalmopathy is a relative contraindication for radioactive iodine, and absolute contraindications are pregnancy, breastfeeding mothers, and desire for pregnancy within 6 months. There are few side effects of radioactive iodine. There can be a transient hyperthyroidism due to insult to the gland, thyroiditis, and sialadenitis. There is an increased risk of thyroid cancer and leukemia, and for this reason, the radioactive iodine is used with caution in children. Thyroidectomy is indicated in patients with poor compliance with medication and contraindication for radioactive iodine, such as severe ophthalmopathy, pregnancy, and breastfeeding. It is preferable in children, patients with large goitre, severe disease, and suspicious thyroid nodule. Total thyroidectomy is the procedure of choice in Graves' and toxic multinodular goitre. But in toxic nodule, the hemithyroidectomy is done. Next, we will discuss about Graves' disease. This is the first common cause for thyrotoxicosis with hyperthyroidism. Graves' disease is an autoimmune condition which is mediated by TSH receptor antibodies. It is more common in young women, but it can occur at any age. The cause of Graves' disease can be environmental and genetic factors. Environmental factors are stress, emotion, smoking, radiation, and infections with Yersinia enterocolitica. There is an associated genetic factors in Graves' disease, as 50% of patients have a family history of autoimmune endocrine disease. So what happened to the tissue level in Graves' disease? There will be an infiltration of thyroid with inflammatory cells. This will lead to the hypertrophy and hyperplasia of the thyroid follicles. Outside the thyroid, in extrathyroidal tissues, there will be an immune cross-reactivity with cells which express TSH receptors. It is present in retroorbital and connective tissues. This leads to inflammatory cell infiltration, edema, and fibrosis. The presentations of Graves' disease. There is a triad of presentation in Graves' disease. That is, the Graves' disease presents with diffuse goitre with thrill and bruit, symptoms of thyrotoxicosis, and ophthalmopathy. Other than this triad, the Graves' disease can present with vitiligo, dermopathy such as pretibial myxedema, pruritus, palm erythema, and the thyroid acropathy such as finger clubbing. Ophthalmopathy is the hallmark of Graves' disease. It is present in 30% of patients. There are two reasons why Graves' ophthalmopathy occurs. They are due to sympathetic overactivity and infiltration. The innervation of the levator palpebrae superioris is partly under sympathetic control. This retracts the upper lid to cause the lid retraction, lid lag, and a staring look and wide palpebral fissure. Dilated pupils are due to increased sympathetic pupil dilator tone. Edema and infiltration by mononuclear cells of the orbital fat and extrinsic muscles of the eyes will cause the infiltrative ophthalmopathy, such as exophthalmos, proptosis, chemosis, periorbital edema, and ophthalmoplegia. One of the common questions regarding the ophthalmopathy is whether this is reversible with treatment of thyrotoxicosis. Mild ophthalmopathy improves with treatment of thyrotoxicosis, but severe ophthalmopathy is not. So, severe progressive ophthalmopathy needs high-dose steroids, orbital radiotherapy, or sometimes surgical orbital decompression. Investigation to confirm the Graves' disease is with thyroid autoantibodies, especially TSH receptor antibodies. Graves' disease is suspected with the triad of goitre, thyrotoxic feature, and ophthalmopathy. It is confirmed with TSH receptor antibodies. So the thyroid scintigraphy is not required. It is done if the diagnosis is still uncertain. The complications of the Graves' thyrotoxicosis are thyroid storm, excess catabolism of muscles and bones, then osteoporosis and cardiac complications. Thyroid storm or thyroid crisis is a life-threatening complication occurs during and post thyroidectomy if the surgery was done in uncontrolled hyperthyroid patients. The treatment modalities of Graves' disease are, as we discussed earlier, antithyroid medications, radioactive iodine, and total thyroidectomy. Most patients with hyperthyroid Graves' disease are euthyroid by 4 to 8 weeks of treatment with carbimazole. If the intention is to induce a remission, antithyroid medication is typically continued for 12 to 18 months. If any relapse following cessation of antithyroid medication requires definitive treatment with radioactive iodine or surgery. In surgery, the total thyroidectomy is the procedure of choice currently. Previously, a subtotal thyroidectomy was performed, but 10% develop a recurrent thyrotoxicosis and 70% develop hypothyroidism. This is the reason why total thyroidectomy is currently performed. Graves' disease in pregnancy. The maternal TSH receptor antibodies in Graves' disease in pregnancy can cross the placenta, and this can stimulate the fetal thyroid and lead to fetal thyrotoxicosis. At the same time, if the pregnant mother is on antithyroid medication such as carbimazole, this can cross the placenta and cause fetal hypothyroidism. Because of this reason, the propyl thiouracil is preferred over carbimazole in Graves' disease in pregnancy. So we have discussed earlier that there are two antithyroid treatment regimes available in Graves' disease. That is, dose titration and block and replace therapy. But block and replace regimen is contraindicated in pregnancy as thyroxine or T4 crosses the placenta less easily. Radioactive iodine is contraindicated in pregnancy with Graves' disease. Total thyroidectomy is the definitive treatment of choice, and it is done in the second trimester. The second common cause of thyrotoxicosis with hyperthyroidism is toxic multinodular goitre. This is a known cause for secondary hyperthyroidism and commonest cause of thyrotoxicosis in the elderly. Toxic multinodular goitre commonly presents with subclinical hyperthyroidism where the TSH is low and the T3 and T4 are normal. Antithyroid medication does not result remissions in toxic multinodular goitre, so the definitive treatment is total thyroidectomy. The third common cause of thyrotoxicosis with hyperthyroidism is toxic solitary thyroid nodule. Toxic nodule occurs from teenage years to old age. If we recall whatever we have done previously, the Graves' disease occurs in young people and toxic multinodular goitre occurs in elderly, and toxic nodule occurs from teenage to old age. And toxic nodule is invariably benign. So in this condition, the FNAC is not required compared to the other types of solitary nodules. Treatment is mainly hemithyroidectomy, but the euthyroid state to be achieved with antithyroid drugs prior to surgery. So far, we have discussed the thyrotoxicosis with hyperthyroidism. In that, the common causes are Graves' disease, toxic multinodular goitre, and solitary toxic nodule. The next condition we will touch is thyrotoxicosis without hyperthyroidism. The causes for this are thyroiditis and ingestion of thyroid hormones. Thyroiditis. In this, the inflammation of the thyroid gland causes destruction of thyroid cells, releasing stored thyroid hormones without an increase in synthesis. There are three kinds of thyroiditis: acute, subacute, and chronic. Acute suppurative thyroiditis is an acute life-threatening endocrine emergency. This rare condition is due to Staphylococcus or Streptococcus species. These infections cannot spread to the thyroid gland directly because of the tough capsule. So the spread can occur through piriform sinus fistulae, neck or pharyngeal abscesses, or penetrating trauma. There can be a lymphatic or hematogenous spread as well. Acute suppurative thyroiditis will present with painful anterior neck swelling and fever. This life-threatening condition can cause airway obstruction. So the airway management in the initial stage is important. Broad-spectrum intravenous antibiotics are often curative. CT of the neck and mediastinum is helpful for further management. Ultrasound guided drainage is necessary in some patients with fluid collection, and the surgery rarely performed. The common example for the subacute thyroiditis is D. Cowain's thyroiditis. It is due to viral infection. So, any patient presents with the history of viral illness followed by painful thyroid swelling, we have to suspect D. Cowain's thyroiditis. In investigations, the serum C-reactive protein and thyroglobulin are elevated. It is different from Hashimoto's thyroiditis in that the thyroid autoantibodies are absent in D. Cowain's thyroiditis. Ultrasound scan shows an enlarged thyroid gland, and the thyroid scintigraphy revealed reduced uptake. Treatment is usually symptomatic. The main management is non-steroidal anti-inflammatory drugs and beta blockers. In severe cases, steroids will be added. Hashimoto's thyroiditis is a chronic thyroiditis. It is usually asymptomatic. So thyrotoxicosis is temporary in Hashimoto's thyroiditis. Majority returns to euthyroidism, but only about 20% will develop hypothyroidism. These patients present with painless thyroid enlargement and compressive symptoms. The compressive symptoms are disproportionate to the size of the goiter. If we consider the treatment, the Hashimoto's thyroiditis does not need any treatment in majority of cases. But if the patient develops hypothyroidism, it should be treated with thyroxine. Surgery is reserved for compressive symptoms or suspicious lesion. The other condition that can lead to thyrotoxicosis without hyperthyroidism is ingestion of thyroid hormones. There are three abnormalities that can lead to thyrotoxicosis due to the ingestion of thyroid hormones. They are factitious, iatrogenic, and Hamburger. Factitious thyrotoxicosis is due to the intentional ingestion of thyroxine for reasons other than functional abnormalities of thyroid, such as weight control. Iatrogenic thyrotoxicosis is due to accidental increased intake or overtreatment with thyroxine. Hamburger thyrotoxicosis presents due to the inadvertent ingestion of thyroid hormones in minced beef containing thyroid tissue. So, in this lecture, we have discussed the functional abnormalities of the thyroid gland. In that, we have discussed the hypothyroid state and thyrotoxicosis. Thyrotoxicosis can be with or without hyperthyroidism. In the next lecture, we will discuss about the morphological abnormalities of the thyroid gland.